Welcome to Intention to Treat from the New England Journal of Medicine. I'm Rachel Gottbaum. Today, we are going to talk about the world's #1 inherited heart condition. It's called hypertrophic cardiomyopathy. It's the most common cause of sudden cardiac death among athletes, and it can affect children or adults. Yet most of us don't even know we have it.
My name is Lindsay Davis. I'm 38 years old, and I was diagnosed with my heart condition, hypertrophic cardiomyopathy, when I was 17.
My name is Karen Newstrom. I am 65 years old. When I was 44, I was diagnosed with hypertrophic cardiomyopathy.
So before I was diagnosed, I had a few years in my teens where I was having symptoms, and my mom took me to doctor after doctor. I was misdiagnosed with chronic fatigue syndrome, with asthma. It wasn't just one doctor for me. It was many different doctors that took a look at this young ballerina, this athlete who was dancing 7 days a week, and thought it could be anything but heart disease.
We have had 4 generations of my family diagnosed with the disease. I have 2 brothers who died from sudden cardiac arrest. They were both diagnosed with HCM. They had not yet pioneered the use of defibrillators to prevent sudden cardiac arrest. The first brother was diagnosed at 16. He did die from a sudden cardiac arrest at 20. After that, my father and another brother were diagnosed with it, and my second brother died 10 years later at the age of 34. I was not diagnosed upon my first brother's death. All they told me was that I had an innocent heart murmur, which is a very common diagnosis for HCM patients.
Sometimes we judge people based on what they look like or based on how they've lived. And for me, I was a young girl who was super active, and the preconceived notion is this girl is really healthy, but I was concealing something very deadly.
I had a neighbor who happened to be a cardiologist, and when he heard my story, he recommended that I get my children checked as well as myself, even though I had been checked once before that time. We got a call saying that one of my children had suspicious thickening. So they followed that son until he graduated from high school. When he was in college, he was ready for a pickup basketball game, and he fainted, and a positive diagnosis of HCM was made. After my son was diagnosed, it was recommended that the rest of my children and I myself get screened again. Theirs came back as negative, but mine came back as being positive for having HCM.
I was constantly out of breath. I would be walking around the block and just feel like I had to take a nap after. I would have this tightness in my chest every so often that would just feel like someone was constantly squeezing your heart harder and harder. Everyone was just like, I don't know what's wrong with you. Why don't you sit in the shade? Why don't you drink some water? Did you eat enough today? And it wasn't until after a dance class that I had a collapse. That particular day, I went to dance class like normal. I noticed that I was feeling really heavy. It felt like I was quicksand. And I went home. I was resting and I got up, started walking down the hall to tell my mom I wasn't feeling well, and I collapsed, and she called an ambulance and I was taken to the Cleveland Clinic. And a cardiologist came in and he just quickly ruffled off a diagnosis and said, "You have something called hypertrophic cardiomyopathy." I then asked the doctor, "What does this mean?" I thought that only old people get heart conditions.
After I was diagnosed, while we were still in the exam room, it was decided that I should get a defibrillator. Within 14 months, I received my first appropriate shock. It happened in the early morning. I was sleeping and I awoke with a jolt. My heart had gone into fibrillation. It was beating over 200 beats per minute. It meant I was going into cardiac arrest, the same thing that killed both of my brothers. And to return my heart to a normal heartbeat, my defibrillator shocked me.
The medications that I took just made it hard to breathe. It made it hard to remember things. It was just a really difficult thing for me to know, like, these things are making me feel worse, but somehow they're actually better for me, which didn't really make sense to my head at the time. I had another collapse and they decided it was time for me to have a defibrillator implanted. That defibrillator inevitably broke, and I had an incident where I was walking and randomly, as I was crossing the street, I got shocked by the defibrillator and it knocked me down in the middle of the street. It was a really scary experience.
I was a kindergarten teacher and I was out of breath going up and down the stairs. I could not walk from our middle door in the school down to the office. I could not walk that hall without stopping to sit because I would get out of breath. It wasn't until I called about having the shortness of breath that they made the realization that I needed to have the surgery, a septomyectomy, because I was in heart failure.
It's really difficult to have a normal life as an HCM patient. I can have a day where I will hit those 10,000 steps on my tracker, or there will be a day that I can literally only walk to the grocery store that's like half a block away, and I have to then take a rest when I get to my lobby, sit on the bench, and just have to deal with the heart condition. And it has a mind of its own.
HCM is more common than many other diseases that people are aware of. It's more common than cystic fibrosis, multiple sclerosis, muscular dystrophy, ALS, all diseases that people know and have heard of. It's important that people are aware of it because they may have the symptoms and not even realize it. And it can be a life or death situation.
It would be wonderful to one day know when I wake up, I'm not going to be short of breath walking across the room, know that I'm able to walk to the grocery store without having chest pains. It would be lovely to just live a normal life.
There are others in my family who do have HCM also. My niece has had a septomyectomy as well. One of my children is looking at having the surgery in the next few months. I have also a grandson who has it, and I hope that my grandson doesn't have to go through what I went through, that by the time he needs to have something done, the medicines that they are trying right now, that they have something that helps cure or at least ease the disease.
Welcome to Intention to Treat from the New England Journal of Medicine. We're now joined by Dr. Martin Maron. Dr. Maron has spent his career researching new ways to treat hypertrophic cardiomyopathy. His father, Dr. Barry Maron, pioneered the use of the defibrillator in HCM patients. Dr. Maron has published a study in NEJM about new medications that could change clinical practice worldwide for HCM. So, Dr. Maron, let's start by talking about what this condition is and how it's different from other types of heart disease.
Hypertrophic cardiomyopathy, first and foremost, is a genetic heart disease, the most common genetic heart disease in the world. So the patients are born with a mutation that ultimately causes there to be structural changes to the heart muscle. And the most classic of that is there's an increase in wall thickness for the heart. And that's really what increases the risk for some patients of complications at some point in their life.
So who does HCM affect?
It's a global disease. It is a disease that is found almost in every country of the world, equal by gender and race. And so it really affects a worldwide community of people. It's the most common cause of sudden cardiac death in young people, including sudden death in young athletes as well. It's also a major cause of limiting symptoms for patients that have this disease of any age.
And when is it typically diagnosed in a patient?
We can diagnose this condition in patients of almost any age, and the most common age at which patients typically present for clinical diagnosis is usually midlife, in their mid to late 40s is the most common time that patients will develop symptoms that ultimately lead to diagnosis. But again, the range is enormous, from all the way from infants all the way to the 80s even. So it's got an enormous spectrum in terms of when patients are diagnosed.
The majority of people who have HCM are not actually diagnosed, and when diagnosis happens, it's usually after sudden cardiac arrest. Why do you think that is?
You're right. There is a huge gap between the number of patients that have it and the ones that are diagnosed. First of all, 10%, so 1 out of 10 HCM patients, the EKG is actually normal. So you would have no idea, at least normal by our conventional way of looking at it. It's completely normal. In the other 90%, there may be some abnormality, but there's no specific pattern that says this is HCM. And for most patients with this condition, they do pretty well, actually, okay? And they don't ever come to clinical diagnosis or need treatments. I think the other issue, the issue of sudden cardiac death, and that has a predilection, meaning for age in this disease, of younger patients. So it's actually kind of paradoxical. It's actually younger patients with hypertrophic cardiomyopathy that are the greatest risk for sudden cardiac death. And for most of those patients, they are otherwise asymptomatic. So they don't have any other symptoms that would trigger diagnosis. And so often in those situations, then the first manifestation, unfortunately, of disease is an event like a sudden cardiac arrest.
So if you don't generally see something in a normal EKG, how do you diagnose this disease?
Well, the way you diagnose the disease is that you have a suspicion of some sort, either from the EKG, normal EKG pattern, there's a suspicion, not a definitive diagnosis, or you have a family history, or the patient has symptoms that could be attributed to a disease like hypertrophic cardiomyopathy. I think what we see a lot is that younger patients that have shortness of breath, for example, they kind of don't end up getting a reason for that. The evaluation sort of stops after, for example, 1 or 2 tests that are unremarkable. And they kind of then get lost, in the system, We've got to do better there. We've got to say, wait a minute, if this doesn't tell us the answer, we've got to look at this, and this, for which one of those is hypertrophic cardiomyopathy. That's what we need to do better at.
So let's talk a little bit about the evolution of our understanding of this disease.
It's a story that begins with the first patient identified with this condition, hypertrophic cardiomyopathy, in the late 1950s. And that patient was diagnosed by Dr. Eugene Brunwald, probably one of our most famous and influential and impactful cardiologists of our time, who made the diagnosis and actually first characterized the disease. And at that time, there was nothing to do for those patients, right? I mean, Dr. Brunwald made the diagnosis in the first patient and sent that patient back to West Virginia with nothing. And so we went from nothing to evolving over time to certain drug treatments that helped to improve a little bit how patients feel, to the evolution of surgery, which was an important therapeutic option for some patients, to catheter-based procedures as well, and ultimately the application of the implantable cardio defibrillator to protect patients against the most devastating consequence of the disease, which is sudden cardiac death.
So basically, you can prevent sudden cardiac death with defibrillators. And for patients who undergo major open heart surgery, severe symptoms can be improved. But clearly with your new work, you wanted to do more.
I think what's fair to say is that medical therapy in this disease, hypertrophic cardiomyopathy, has fallen short in terms of being able to provide patients what they really need. Often on a day-to-day basis, patients face situations where they experience shortness of breath with fairly routine activities, even things as simply as going up one flight of stairs. They're out of breath. For some patients to wonder whether or not at some point you could experience a potentially life-threatening rhythm. That's a huge weight to live with. So that really, tells the story that we really haven't had the kind of access to effective medical treatments for this condition that the patients deserve to have.
And these are young people for the most part?
The vast majority of patients with hypertrophic cardiomyopathy are otherwise healthy. They don't have a lot of other, comorbidities. They're often, as you just said, young. The average age at which patients present with this disease is in your 40s, as opposed to many other cardiovascular diseases like coronary artery disease, where the presentation is much later in life. So you're talking about relatively younger patients, generally otherwise healthy, who are really being limited on a day-to-day basis by substantial symptom burden that frustrates them and impacts their quality of life.
So now there's a new medication. Tell us more about what your research has found.
What this study showed was that we could take patients who are very symptomatic and very limited in terms of their exertional capacity, very frustrated with the impact of symptoms on their day-to-day life. And what we could do is with this drug, we could convert them over a very relatively short period of time to substantially improving how they feel, decreasing their symptom burden substantially, and also enhancing their ability to engage physically with exertional activities. Okay? So I think the two big messages there are that this therapy took patients who were very limited and significantly improved how patients feel and how they function.
And to be clear, the trial involving this medication had a different goal than we've typically seen.
Historically, clinical trials for most diseases have been predicated on endpoints, assessing the efficacy of a treatment, because that treatment makes patients live longer, which is obviously still very important, or decreases their hospitalization rates. In hypertrophic cardiomyopathy, the rates of those two things, mortality and hospitalization, fortunately for the patients, is very low. So what matters most to patients is how they feel and how they function. This really underscores that we're transitioning to designing studies now that are, in fact, incorporating more patient-centric endpoints that are focused on how patients feel and function and make a big, big difference in the lives of patients. And I think that itself is also an important and transformative aspect of this study.
So let's talk about how this medication works. What's the science here?
In hypertrophic cardiomyopathy, the vast majority of patients have what we call obstruction to blood flow out of the heart. So sort of like when you have a garden hose and you clamp down on that, water backs up in a finite space. In this way, it's the same idea. Blood's backing up in the heart, in the small chamber. And what happens then is that the pressure is increased. And those high pressures are what drives patients' symptoms and decreased exercise capacity. And so the mechanism of action of the drug is that it works by decreasing slightly the force that the heart is contracting. And by doing that, you get rid of the obstruction to blood flow, you normalize the pressures in the heart. And that is really what ultimately makes patients feel so much better.
So what's next in terms of what may be possible here with this approach?
Well, I think that this approach or this kind of therapy could be applied potentially even earlier. Again, we're talking potentially here in the future, could be applied earlier in the natural history of patients. Maybe it will have even more benefit if it's given earlier to patients. It's also possible that based on the mechanism of action of the drug, that it could have benefit as well in other heart diseases besides HCM that act or perform in a similar way to hypertrophic cardiomyopathy, but are not exactly the same. A therapy like this could also potentially provide benefit to that population.
So let's talk about how a medication to treat symptoms can change the global impact of this disease.
Oh, potentially huge. I mean, the current therapies that we have, medical therapies, fall very short in terms of efficacy, and the invasive procedures are not widely available. Certainly, when we talk about worldwide, very few access to invasive procedures. So I think the potential here, the greatest potential perhaps, is the impact of this kind of treatment in the global HCM community. And I think we're going to see enormous benefits to patients that have never had access to anything to help them. And I think that translates ultimately to increased recognition of the disease in a way that we haven't had before. And that ultimately translates into better identification and diagnosis, and of course, more effective and earlier interventions in therapy for those patients. So it improves the care. And what I hope comes out of this is a momentum to create an infrastructure that we've never had before to deliver this kind of therapy that will alter the natural history of patients in an effective, reliable, hopefully affordable way, no matter where they may be living on planet Earth.
Dr. Marin, thank you so very much for joining us.
Thank you very much.
Dr. Martin Marin is director of the Hypertrophic Cardiomyopathy Center at Lahey Hospital and Medical Center. We had help from Deputy Editor Dr. Jane Leopold. Our managing editor is Deborah Molina. Mike Toda is our engineer. Next time, obesity and diabetes in kids is a major problem. But are the newly approved weight loss drugs the answer?
There are very few pediatric providers that feel knowledgeable or competent prescribing these medications. And we don't have a lot of data to guide us. And I have a lot of hesitation about prescribing a drug to a child that is lifelong.
That's next time on Intention to Treat from the New England Journal of Medicine. I'm Rachel Goppak.